So how we got here is what is malperfusion for patient with acute aortic dissection? So I'm going to focus on type A, and I think Kim has spoken about type B and malperfusion. So this came up from malperfusion syndrome and managed with emergent open repair. That is the classic training. You take the patient with malperfusion with type A aortic section to the operating room for a central repair first, and then hoping that will fix the malperfusion. However, as we all know, and work is done over the years, like this has changed in certain patient and in select patient in the absence of rupture and tamponade. There is now a trend to take the patient to the hybrid suite and fix their malperfusion before you do a central repair. So you can avoid with that hypothermic stroke arrest and a patient who's acidotic, who's terribly sick, and you give them a time to heal and so on. So at least the hypothesis is upfront endovascular fenestration or stenting of the aorta or branch vessel. Give select patients a time to recover, put them in the ICU for a day or so, and then you take them back for a repair. Otherwise, would have been a futile operation. So next slide, please. So this is the work of the great David Williams from Michigan, and you all know that the malperfusion is a holistic approach. It's clinical, radiological, and laboratory, and it's not one thing per se. So you could have clinical, but not radiologic or radiographic, and so on. So it comes in different flavors, or 3 flavors: static so static and dynamic, and it could be both. Combination depends on the circumstance, and the treatment could differ based on that. So next slide, please. So the idea is when you treat patient with static, I think that's a work of Michigan, is you got to have to confirm that if the patient has a blood pressure difference or pressure difference from the ascending to the branch of 15 millimeter or higher, that this constitutes probably a radiographic on top of clinical malperfusion, and this patient needs probably branch vessel stenting. Next. So this is how it's been done, and I think that we changed that a little bit here at UT. Actually, we do this now regularly. We try to do septotomy on acute and chronic dissections in part of a branch repair or sometimes an acute repair. And it's IVUS guided. You put a catheter in. Usually nowadays we put the catheter in one in true, one in false, and you put a snare in the false lumen. You put the target vessel. You put the catheter towards the bullseye, and you confirm in multiple views. And then you poke the septum. What we do nowadays, and this is going to be described next week at the VAM meeting and the SBS, is we connect this to electrocautery, and we can actually do a septotomy based on electrocautery and create a very nice, very safe septum. So next, and the idea is you create this connection. Next slide, please. And then you go ahead and you stent that, and this stent equalize the pressure in both compartments. This person, remember, showed up with a type A aortic section. You now equalize the pressure. You fix the malperfusion. Give the person a day or two to heal, and then you take them for a repair. Next slide, please. And so this is the algorithm, the one based on Michigan and the other one based on Emory. So the one in Michigan is the only difference between them is one is endovascular fenestration, the other one is you put a T-bar. And essentially pretty much the same. You delay the repair, the concept is the same, it's just the endograft is different. So, I mean, the repair is different. Next slide, please. I have to wrap up in a little bit, go on. Next slide, please. So the 20-year experience of Michigan showed essentially that patient that has as the experience grew, the salvage of these patients had gone up. and many of those patients avoided futile repair. So that's the idea of you avoided futile repair and you save more than, otherwise a mortality of 80%, they cut the mortality close to 40%. So close to half of those patients, or you avoid the repair altogether. So it's pretty actually good deal if you think about it. Next slide, please. And that is the updated experience also from the Emory group. So again, next slide, my nurse is telling me I gotta wrap up. And then the summary, essentially the absence and rupture or tamponade, those patients should go to the hybrid suite and get a stent, repair and collecting the mesenteric perfusion prior to the repair. Next. And I think actually this is a great deal, and I'm glad that we have a great number of aortic leaders in the audience. I think it's a great topic for a small but prospective randomized trial, because you don't need really much to do that. It's all you need is a 30-day mortality, small number of patients. You can actually collect them pretty fast with a high power, and a clinical trial could be completed within 1 year and less than $1 million. If anybody has any interest in doing that, please give me a call or an email or Twitter or any of those. So again, I apologize for going fast through it. And again, thank you, Arturo, and the organizing committee. And I would have loved to take any calls, any questions, but I gotta probably split. And muchas gracias para todo.